a couple is trying to conceive for one full year without success, then we start thinking about subfertility. Most couples will deliver in the second year without any intervention.
Yes.
But the environment should have been ideal.
Ideal.
If you find that we have a woman who does not have a uterus, and these are now a special group of women whom special group of people whom I think we, as Africans, we are not aware of, and we might be mistreating them, because I've seen some comments on social media.
Welcome back to the Mamatoto Lounge. We are here for you. We are doing it bigger and better every day. We are live at Little Cave, Kisumu at Tomboya Estate. Please visit them. They have a restaurant and very good accommodation. So we are back, and guess what? Daktari is here with us in our specialty corner. All your concerns, all your beautiful questions, either from the conversations or just from your life experiences. Remember, this is all about parenting unfiltered. Our guest has been here before. You know him, you know his story. Today he's here as a profession. We will dig in and we are ready to learn and unlearn. Daktari, welcome back and glad to have you.
Asante sana.
Yes. Yeah. Please introduce yourself, and don't forget that to have every second of you is highly appreciated.
Nimeshukuru. My name is Dr. Onyangondonga. I am a gynecologist at JOTRH. I am also the chairman for KMPDU Nyanza. I think that captures the spirit of introduction. Yes.
We are doing well.
Thank you.
So, Doc,
yeah,
your work is beautiful.
Thank you.
And as an OB-GYN, I look at you people as people who take care of a whole community.
Yeah.
Because it's a mother who is carrying baby or babies who are the future.
Sure.
So that's a whole community. And your work is really, really, really heavy. So whatever you do, however you do it, please keep going. It's a community that you're taking care of.
Thank you.
That's for you and your colleagues as well.
Asante.
We want to be pregnant.
Okay.
I don't know what's your experience, but I find mothers coming in to your desk when they're already pregnant, and some even come last trimester, when the birth is obvious. But when is the ideal time that I, as a woman, and my spouse should start hunting or looking for an OB-GYN?
Thank you. You know,
and in terms of pregnancy,
in terms of,
yes.
Okay.
Yeah.
Thank you. You know, we the Kenyan is cultured to not tell people that they are doing a good job. So I am here for this. I'm very happy that you have said it. I think even if I don't come out with anything out of this, I'll remember that somebody said we are doing a good job.
Thanks, Santi.
So for our women, for our mothers, when is the best time to get a gynecologist?
Yes.
I think the best time to get a gynecologist is as long as you are alive. The field of gynecology has so many different levels of subspecialists.
Okay.
The gynecologist is a general doctor in the field of women's health.
All right.
There is an adolescent gynecologist who deals with our young girls and contraception, because these are things we don't talk about.
Yes.
Remember.
Yeah.
Our young girls are getting pregnant, and some of them don't even understand their bodies. So we have that professional that deals with adolescents and their issues. We have these gynecologists that are dealing with the women who are outside the reproductive age, the geriatric, we call them geriatric gynecology. We have MFM now dealing with women who are pregnant. We have contraception specialists. So all these levels of women
Yes.
are covered. So that when you ask when is the best time for a woman to get a gynecologist, it is any time throughout their lives.
Yeah.
Now, for the woman who wants to get pregnant or who is pregnant, the one who wants to get pregnant, the best time is at the point at which they feel like, I am ready. And remember, pregnancy is something you prepare for.
Yes,
remember, we said pregnancy is not an illness.
It's not
that
an
you say
illness.
niliamka nikisikia kichwa inauma. You don't wake up ukisikia you're pregnant. You see, so it means it is something you should prepare yourself. Prepare yourself for.
Yeah.
So as soon as a couple, or nowadays we have women who want to conceive without necessarily being part of a couple or without being part of any union. So as soon as a woman you feel like, I want to get pregnant, that is the next best time. Remember, the best time ishapita, but that is the next best time to get your gynecologist. And your choice of gynecologist is personal. In fact, I want to bring into your attention the recent comments by our governor from Nakuru, who said she did not want to be seen by her doctors. And I want to say, as a doctor, I support her stance, not from the point of view that these are junior people or these are Africans, but from the point of view that it is her choice.
Her choice.
So for you as a woman who wants to be seen by a gynecologist, it is your choice. You can choose a male gynecologist, a female gynecologist, an old gynecologist, a young gynecologist, a certain gynecologist of a particular religion.
Yes.
You are allowed to choose, because that is what will make you comfortable.
True.
To pour out your issues.
Yes.
Because imagine if I force you to take up, gynecologist you don't want, you will sieve the information you're giving them.
Yes.
And you will feel comfortable when they want to do certain things for you or to you.
Yes.
Yeah.
That is very true, because I've seen women traveling everywhere just to see that
particular person. Allow them.
And just the same that you said, it's not an illness.
It is
so
not.
Because it's not an illness, I have a choice.
You have a choice. You have a choice. You have a choice. And because we are now churning out more and more specialists, we want them to be out there, so that people have an array to choose from. The goodness of choice is that you have a number.
Yes.
So the more we are, the better.
The better for
and people
everyone.
Can say now, I want Onyango, I want Shikari, I want so and so.
Yes. That is beautiful. So let's talk about this immediate time now that I am planning. I want to have a child. So what do I expect when I'm knocking on your door and good morning, doctor, I want to be pregnant? It looks so vague, like, so what?
Yeah, it is.
Yeah.
The goodness is that that particular decision is like a vision and a mission. Okay.
Wow.
You want to get pregnant.
Yes.
And the reason you've come is you want to be led through that path, avoiding the potholes, avoiding, the thorns and everything, to make sure you get to the other side as safe as possible.
Yes.
So this path is called a preconception care.
Preconception care.
Yes. And preconception care is how do you handle yourself as you prepare your body for this new visitor.
Yes.
Because the baby is like a visitor. If you are receiving a visitor in your house, if you've not done your laundry for some time and everything, you do all these things. And sometimes everything. Unatoa kila kitu nje. And even if you've been taking omena, I love omena, the whole week, this time you would want to know, this visitor of mine, do they mind omena, or I want to go and buy something else?
Yes.
So you prepare wholly. From meals, yourself, everything. So what does preconception care entail? preconception care will need both the man and the woman to be ready for this pregnancy if they belong to that union. Okay, so that means that for preconception care, we need to first find out can we get pregnant, because one of the most something that sometimes hits us with we get blindsided with is that you are trying to get pregnant and it is not coming. So all this you have to be aware of. In the West, we do something called by West I mean Western world, not Western Kenya.
Oh,
we are in Western Kenya.
We are
right
in
now.
Western Kenya.
We do what we call genetic counseling on top of preconception. By genetic counseling is what do we expect if we are to get pregnant. All these things are happening before you get pregnant.
Yes.
Are there any inherited conditions that I might be exposed to? And I think we can even do it here in Africa. Am I a sickler?
Oh, yes.
Does my family have sicklers? Do we have albinism in my family? Do you have albinism in your family? These are things that you can counsel a couple on, even as they start thinking about getting children. One of my friends, and I would call them mentor, once said that we have the treatment for things like sickle cell. We have the treatment is genetic. It is controversial. Whatever I said was controversial, but it is genetic counseling. We can genetically counsel our people so that we avoid getting children with sickle cell. Yes, you can choose. So ethically or religious, if you look at it from the religious angle, it might be a bit tricky. So there's that genetic counseling, and then we have things like diet. That couple or individual that feeds on processed meals is one, reducing their fertility, and yes, your sugars and everything are making some changes in your body that make conception a bit difficult. So we can talk about all this in conjunction with the nutritionist. Exercise. I am a very big proponent of exercise, because when you exercise, it reduces your propensity of being obese and all these things, which makes conception easier. When you exercise and your diet is proper, it reduces the possibility of you getting these chronic conditions in pregnancy, like hypertension and diabetes. Okay? When you are exercising and the diet is okay, then it makes you avoid being on that spectrum of obesity or being underweight, because when you are underweight, you have issues with your menstrual and your ovarian cycles, which means getting pregnant is also difficult. That is why you might see that there are some athletes that might have that problem. They don't see their cycles regularly. Okay? So there's so much for us to talk about in preconception. And now when we talk about you preparing the meal for the visitor, how do you feed yourself? What are the things that you need to supplement in your body, like iron? Sometimes I tell the women that I see that you might start taking your iron supplements even before pregnancy, especially if you have low HB, sometimes I tell them you might want to take folic acid even before you get pregnant if there is that history. We've done your genetic counseling and we found that maybe there was that one pregnancy where the child had some issues. We might start taking some supplements now. Okay, so there's so much to talk about in preconception, so that you are ready, your body is ready, and that sort of creates that environment for that baby. But if the baby is introduced to an environment that is not prepared for them, that's when a lot of things go wrong. We lose the pregnancy. You start getting conditions in pregnancy that are difficult to manage. I
love when you have given the version of expecting a visitor.
Yeah.
And it makes me just dive into, there are many people sometimes, I think a huge percentage, like the firstborns are all oops moments, like, oh, tumepatikana. But people tend to do better in their consecutive pregnancies. But there are this couple or couples who they don't even have an oops moment. Actually, their oops is like, we were not pregnant, because they've been trying, and then now there's that moment of, no, I think there's something wrong. So anything different that can be done?
So now that is the benefit of preconception care. It is through preconception care that we can catch some of these scenarios early. Because if you are not going through any preconception care, then you might get into your 5th year trying.
Oh, yes.
And so nobody is telling you that, oh, there's a problem that we can sort. And some of the problems are easily sorted out, by the way. Yeah, some of the problems are easily sorted out.
Oh,
yes,
wow.
some of them are.
Yeah.
Some of them are just, some treatment of some, issue and you conceive.
Yeah.
So now, what you're describing is what we call, in the past it was called infertility. But you see, that's a very heavy term.
It is.
And
scary.
Yes, it is very scary. So we sometimes say subfertility.
Okay.
Subfertility, just to mean that. When a couple is trying to conceive for a 1 full year without success, then we start thinking about subfertility. Most couples will deliver in the 2nd year without any intervention.
Yes.
But the environment should have been ideal.
Ideal.
Yes.
The visitor. Yes.
The environment should be ideal.
Yes.
So that even if your 1st year was not successful, the 2nd year might be successful. Because sometimes you find that the couple is just fine. They're just taking a lot of coffee. For example, one of the things that your nutritionist will tell you about, they just take a lot of coffee, 6 cups, 7 cups a day, and they're not conceiving. That's what I'm telling you. Some of them are very simple. They need to stop taking.
Just to stop?
They need to stop taking that amount of coffee.
And they wouldn't know until they come.
Yes. Alcohol, smoking, secondary smoking. So all these are things that we can capture during the preconception period, and you can reduce the number of people coming to seek intervention for infertility.
Yes. Yeah.
But now there are other investigations that can be done. Remember, for a very long time, people used to say that infertility is a problem of the woman.
Yeah.
If you look at our traditional African societies, you'll find that a lot of time when a couple does not conceive, the man is brought a second wife. Okay. Though I know in the Luo culture sometimes what we would do is the woman would get pregnant via one of the brothers of the husband, though in a clandestine manner. Those are our African traditional practices,
like
and we must actually be aware of them, because they also tell us that Africans are not entirely stupid or entirely ignorant.
I agree. True.
We had these issues and we had our own ways of sorting them out. So there are some tests, there are some drugs we can give that can, if you have like ovarian issues, that can stimulate the ovary and you start producing eggs and all those things. We have issues like polycystic ovarian syndrome, which for a very long time has been a misdiagnosis that we've been giving to a lot of patients without proper diagnosis. There's a criteria of diagnosing these things. I don't know how many times I have been in the ward and I see a young girl with a diagnosis of PCOS just from an ultrasound, and I tell myself, okay, did we try to find anything else, because we might subject this girl to some treatment that she does not need. Yes. So yes, your preconception period might try and sort out even this infertility a bit early.
Yeah, a bit
because
early.
imagine meeting somebody at 45, they have not had any conception,
Yeah.
and now
Yeah.
it's when you're realizing that they had a blocked tube or blocked tubes.
Yes.
See, it's a bit late. Yes, you can do those IVF and everything, but it's a bit, they are on that other spectrum of, you know.
Yeah.
So the investigations are available.
They are available.
They are very available.
Yeah.
The interventions are also available. Very much.
Beautiful.
We even have egg donations, we have IVF, we have
so
IUIs.
Before you even mentioned there, that was probably the next of, we have seen a lot of, even in social media, there are even special groups for mothers who are trying to be, they're just many groups, and people come together because I think it's a sense of belonging. Yeah. So unfortunately, what I've seen is an individual goes for a specialist and is given a guide, and they come and discuss the same guide, which for me it's tailor-made for one person. And then mothers will keep trying, and I've seen a lot of multiple pregnancies coming up from probably a treatment that was given particularly for one because of her own diagnosis and journey. How do you, or how should we go about it, treating an individual versus the same prescription being used as now a community?
So I actually have experienced what you are talking about, and some of it has been propagated also by us as medical professionals. Because maybe as a general gynecologist, I have dealt with a woman with infertility. I have given them some letrozole, I've given them some metformin, and she has delivered. So that now I have that penchant that every woman who comes to me with subfertility, I'll give them that same concoction. The problem with that has been because of the lack of fertility specialists and also the capacity to make diagnosis for these patients. But like I've said, we are having better diagnostic models for these patients. So if they need laparoscopy, I know like in Kisumu, quite a number of people doing laparoscopy for diagnosis of certain things. I know we have quite a few of fertility specialists in Kisumu.
Beautiful.
And one thing that I encourage my colleagues, and this probably would be to my colleagues, is just refer the patient to the right specialist. Let me not be a general gynecologist and I want to manage a patient with infertility. What I can do is I can work up the patient, sieve the patient, counsel the patient, and tell them this is the right person to see. And with the level of knowledge that we have with the public, sometimes also if you know that this is what I am being treated for, then you should demand for that level of specialists to take care of you.
True.
Because think about it, if I have an issue with my brain and I am seeing my pediatrician at this idea, they have a general knowledge of what is happening, but they might not help you completely.
That is why you started by even introducing the subspecialties
already
at the OB-GYN level.
Exactly.
Yes.
We encourage our women to, choose your gynecologist, but there's that level like Ifika. You also ask, because that you have that relationship.
Yes.
If they tell you that I think we're dealing with subfertility, the next question is, which infertility specialist would you recommend? You have asked it in a very polite way. You've not told them that you were wezi kazi. You've just told them that which one would you recommend? And they will guide you.
Oh yes.
If they don't guide you to a fertility specialist, then you have a red flag right there.
Yeah.
Yes.
True.
And we should not be afraid of saying those things now. If your specialist insists on treating your your head injury na ni gynecologist, utamwambia tu sasa unajua hapa si mali yako.
Tusonge mbele.
Tafutie neurosurgeon atanisaidia.
That is very good, and it's also very good when I think that's why we are in such a podcast.
Sure.
Because we want our viewers to know that there are so many of us and everybody has something. You know, this fabric, we all need it to make it as beautiful. So we all need each and every hand.
Yeah.
So tunasonga tukisonga.
Yes.
That is beautiful. And what are among the few or many options of a couple that is dealing with the subfertility?
So we first would want to appreciate the different levels of subfertility.
Okay.
There is subfertility that is from the woman, and usually it's the same percentage. Yeah, so si eti kila wakati ni mwanamke ndo yuko na shida. And that's why I think our program in Moi University is called reproductive health, because we also want to encompass the men, especially when you're thinking about endocrinology and infertility. Because a lot of time the woman will come and tell you, I've tried to get pregnant, but she's alone. You have not done a sperm analysis, a semen analysis from the husband. You have not done an ultrasound from the husband. So you are just looking at the woman.
Oh, so Doc, let me cut you short. So right from the beginning, we are coming man and woman.
Yes. You should
from
come
the
as a couple.
Preconception, anytime we are coming, it takes two to tango.
I might not have mentioned this, but it is better. It is a better experience.
Yes.
If the couple that wants to get, if now there's that union, if the couple that wants to get pregnant comes as a couple, so that we begin, so that the message, the baseline message is the same for both of them.
Okay.
Because imagine if you are telling the wife that you don't smoke. She does not smoke. She'll tell you, I don't smoke.
I don't.
But the husband smokes in the house.
Yes.
A full packet every evening.
Whoa.
See now, that secondary smoking is not helping.
It's not.
So you have not solved her problem. In fact, she might move to a different doctor thinking that you are not helping her.
Okay.
Akumbe, you've not solved the main problem. So they come as a couple, you talk to them. They're changing their diet. They're changing their exercise routine. Together.
Oh, okay. Wow.
So that all these things, and you see that's where now the genetic counseling also comes. Because we'll ask them, both of them, do you have a family history of sickle cell? Do you have a family history of albinism?
Yes.
It will come out from them coming together. Maybe not for all of them, but it is good if some of them, both of them are present. Yes.
I'm smiling because of the many stories of even women were forced to, like toka hapa hujatuzalia, because it has always been like a woman.
It is 50-50%.
It's 50-50.
It is 50-50.
Yeah. Until they now come, analyze, and now we say, hapa ndio shida iko.
Hapa ndio shida iko, yes. And then sometimes you might find, actually even both of them have the problem, yes. Sometimes it is both. Sometimes it is only man, sometimes it is only woman, and sometimes we don't even know.
And I know during this infertility, subfertility issues, that is when most men will come out and say, mimi hata niko na mtoto mwingine mahali pengine.
Yes. But you see, that's also part of the history. The reason you go to hospitals, and I think most patients might be knowing by now, but if they don't know, especially when it comes to infertility, the reason we want to talk to both of you, both at the same time and separately, is so that we get to know where do we begin. So both of you will come together, we'll talk in the same room, but then we'll also talk to each of you separately. Because I would want to ask you, do you have another child? Have you ever gotten pregnant? And one of them will tell you yes, or one of them will tell you no, and you would know. Because if you tell me I have another son, uko inje, then I would now start saying maybe the problem is here, but due diligence, let us just confirm.
Let us do this,
Si ati nitakuja kuambia bibi, unajua huyu jamaa yako kwanza amesema ako na kijana hivi. No, that's not what is going to happen. we'll just test, but nitamwambia, you see,
Yeah.
I think the man is okay, so we'll continue further probing from him.
Yeah.
That is why we are, and that's why you should also choose a gynecologist, a doctor that you trust.
That one cannot be
who will
over it.
guide you through
Yes.
this. Yes.
Very
if
good
if you just get people from whenever, sometimes they will rush you through the process, and you might get ukiwa frustrated.
So just now briefly, where you are, what options do we have?
Okay.
Yeah.
So we at the lowest level, we have just treatment of the condition that is causing the infertility.
All right.
If we talk about things like polycystic ovarian syndrome, where the ovary is coming up with the follicle that is supposed to release eggs. So the ovary forms so many follicles, but they don't burst to release the eggs. And then on top of that, they also have, how do I put this? Masculinizing hormones. Okay, so these two are brought about by something called insulin insensitivity. Now you remember why I'm saying your diet, your exercise is very important.
Yes.
Yes. So this PCOS, sometimes it's just because of that insulin insensitivity. So when we treat insulin insensitivity, and that's why you will see a lot of women are on metformin, which sorts out your insulin sensitivity, sorts out your weight, and also now makes the cycle to be able to produce eggs. So sorting out the underlying issue. The underlying issue.
And this nutrition thing, I think, is taking it's almost like 100%.
It's very important. It is very important. And I think nutritionists should really come out and you know, sit down with us even in our clinics.
Kabisa.
And we see the patients that they also pass through the nutritionist.
Yes.
Sit down with them 1-2 hours just to take them through what is proper for them. So at that level, you can sort out the condition, underlying condition.
Underlying conditions at least.
Medical condition. So that one does not need surgery or anything. Then there are those ones that might need you to do surgery if you have congenital malformations of the reproductive system. You can do a corrective surgery. You can there's something called a transverse septum on the vagina, which makes you sort of like have a blind vagina. The sperms cannot get into the uterine. So once you do the surgery, you remove the septum, so you now have a patent reproductive system tract. And then now that is at the level of surgical management. Now those ones that we can neither treat using medication or surgery, then we have other options like IVF. Okay. First, there's something called IUI, intrauterine insemination. Intrauterine insemination probably would mean that maybe the woman had no issue in the reproductive system. They are even producing eggs. So what was lacking was the sperms probably were not getting into the uterus, maybe because of an issue with the semen analysis of the man, or a tract issue, maybe. So you can directly inseminate the sperm into the tract, so that now the rest of the system takes place. So that's a milder one. You stimulate the ovaries and then you inseminate, just like we do for animals. For those of us who did agriculture, just like for the animals. So the insemination can be natural or artificially inseminated. And then now we have IVF, in vitro fertilization. By in vitro fertilization, what it means is that you are doing the fertilization outside the uterus, and then you are implanting the fertilized product into the uterus. In this case, we do this for women who have a uterus that is okay, and an ovary that is okay, that can sustain the pregnancy.
Okay.
Remember, the first few months, or is it days, of pregnancy, it is supported by the hormones of the ovary.
Yes.
Before the placenta takes over. So if you find that we have a woman who does not have a uterus, and these are now a special group of women whom special group of people whom I think we, as Africans, we are not aware of, and we might be mistreating them, because I've seen some comments on social media with regards to people with disorders of sexual differentiation.
Okay.
There are people who are born male and they are not male, or people who are born female and they do not have the things that qualify them as female. They don't have a uterus, they don't have an ovary. So these ones, we can offer them, what is this called? Adoption. Yes, we can offer them adoption.
Wow.
So I've skipped one, the surrogacy.
Okay, this
which has also been a bone of legal contention in Kenya, because for a long time in Kenya, secretly, people have been practicing what we call commercial surrogacy, where some rich people, or rather, let me not put it like that, but those people who are economically endowed would get girls who are trying to make a life for themselves. They get pregnant, they take away the baby. It is not wrong to get a child through that process, but what has been wrong is the commercialization and a possibility of abuse that comes when money is involved, and power is involved. Yes, but it is one of the ways in which women who now either have no uterus, have no ovary, they want to get a child, somebody can carry for them the pregnancy. They can donate an egg, in vitro can be done, somebody else can carry for them.
It is soothing. Should I say soothing? Yeah, to hear that we have so many options.
There are options.
And all these options are very individualized.
Yes.
It is my journey. It is my story.
It is yours, yes.
So, and the doctor is one after the next.
Yes,
you go ruling out until you get that package for me. So to our viewers, all the time we are doing this, we definitely want the OB-GYNers to work with us. Allow them to hold your hand and walk with you. And like you've heard and understood, it is a journey. A journey full of patience, right?
Sure. It is.
I think we'll do the next podcast. We'll do a whole of fertility, infertility.
Yes, the topic
depth,
of fertility is big. It's worrying.
Yeah.
The rural Kenyan might not have gotten that exposure. I remember when I was an MO in Kisumu.
Yeah.
I don't know who gave out my telephone number, but not telephone number. I got a message on Facebook, asking me, "Oh, doc, I have this issue. Can I see?" I told them, "No, me, I might not even help you." But I had to refer this patient all the way to Nairobi to a particular person who I knew was offering this. But now we have so many options available even in rural Kenya.
So we've walked that journey, and we are here. We are pregnant now. So still, we want to start the antenatal clinics. We want to see the OB-GYN. And when do we start, now that we know that we have, especially now that nowadays we buy the test kits at the nearest chemist and we come with the strip?
So first, I think that's the best thing that happened to us. Self-test kits are a very good thing.
Yes.
We have them in pregnancy.
Yes.
And we are trying to also have them in cervical cancer screening, self-administered, so that people are more comfortable with this. You don't need to go to the hospital to come up with such diagnoses But that said, the earlier you know you are pregnant, the better. But again, if you went through preconception care, it means you're preparing for something.
Yes.
And that means you are expecting you to be pregnant. And therefore, you might catch that you're pregnant a bit early.
Yes.
So knowing that you're pregnant early is a good thing, because you now start taking care of your visitor. You sit down with them, you unapigia story, you find out if they want tea and everything, and you would notice if they want something or something is happening to them very early.
Yes.
So the first time you should visit, you should start your A&C visit is the first time you know you're pregnant.
Wow.
So just so that I put it into perspective, we usually say that almost 25% of pregnancies might get lost without even the owner knowing that they were pregnant. But you see, that might be that is a very important information, especially if you will be dealing with somebody with infertility.
Oh yeah.
Because they might tell you, I've never gotten pregnant, and yet she might have lost 3 or 4 pregnancies. And if you knew that she has gotten pregnant before, then you would know when to intervene and where to intervene.
Absolutely.
So it is very important for the very first time you find out you're pregnant. That's the first time you want to go to the clinic. And in this clinic, I want healthcare professionals to change the way we see our patients in our clinic. It is not just to touch the stomach and do their BPs. Yes, all those things are important. But in your first clinic, which you go to as soon as you know you're pregnant, we need to first find out how the mother is doing. You as a woman, are you optimized for this pregnancy? Is your blood pressure okay? Is your blood sugar okay? What is your general health?
Yeah.
You know, what is your serostatus? All these things are important.
Okay.
And then the next thing is you want to know this baby that you now say you have conceived. Where are they? How many are they? What is their time? What is their estimated time of conception?
Okay.
Because that first trimester estimation of conception, or we call it LNMP, but let me just say dating.
Yeah.
When we find the age of that child in that first trimester, then it gives us a very good idea of when do we expect to deliver, so that we don't have those overstayed pregnancies or a pregnancy that is born early. So that is the time to get specifically that date for that child. So for me, if I am seeing a pregnant woman in my clinic, the first time they are pregnant, I would want to do an ultrasound in the first at least before 13 weeks. Around 11 weeks they would want to do an ultrasound there, just to confirm how many babies do you have. Because if you find that you have 4 babies coming up, you had planned for 1, there are interventions for that. Plus, we know the higher order pregnancies have more complications. So sometimes we don't encourage them. So if you have 4 pregnancies coming, we can reduce them to 2, for example. It is possible. I know now ethically there are so many questions that people would ask, but we will sit down, and for you as a patient, you will tell us what you want for this particular pregnancy.
And if there are any complications, this is the time to discuss.
That is the time to start talking about all these things.
I love the fact that you said how many and where. So the where.
You want to know where they are, because the first trimester, you might be very happy I am pregnant, and you find that it is not in the right place. It is in the cervix. Us knowing this is very important, because we tell you that, ma'am, this pregnancy will not get to term, for example. Or it cannot grow where we are. And therefore we might want to safely make sure that you can get pregnant again. You see, if it's on the tube, we'll tell you this we will not get anywhere with this.
With this.
You understand?
Yes.
Yes.
So I love the fact that you say the where and the how many. And also, just having this conversation with you, Dr. Why I also have really much respect is that you are talking to both the patient and your colleagues as well.
Yes.
So it affirms that this is a journey.
It is.
It really affirms. Asante for that.
Thank you.
I am very happy, and I hope our viewers are listening, that regardless to where you are at, we are both learning and unlearning.
Sure.
Beautiful.
Sure.
All right.
And in fact, even the patients will be teaching you at that time.
Yes.
They will tell you new things.
Yeah. And they'll tell you, no, it was like this before this, you know, that deep conversation. The relationship and the choice.
Yes.
So, that is among the other things. What is there something else that we've left out?
Sure.
That's obvious.
There's something also now. You remember we did genetic counseling during preconception.
We did. Yes.
It does not solve all your problems. We have a new problem coming up with our generation. This new problem is we are getting pregnant late. This comes with a lot of other things that people have not been talking about. But nowadays I see a lot of people saying, oh, COVID vaccines are making our children get autism, COVID vaccine. And sometimes I remind them, do you know you used to say the same thing about tetanus vaccine?
Yes.
But nowadays we don't. So it's because we learn and unlearn, just like you say. So there's something called screening, prenatal screening. We want to screen for the common chromosomal abnormalities. It's majorly Down syndrome, because Down syndrome is, I think it is only Down's and Edwards syndrome that these children will be born and they might live for some time. In fact, Down syndrome will live for some time. Most of the other chromosomal abnormalities, almost 75% of them will not get to birth. Those are the ones that we get first trimester abortions. So I used to, when I was that young, I am old. When I was that young, I used to tell some of my patients, as a way just of talking to them after MVS or after abortion, I used to tell them that, look at it from this angle. Most of our abortions occur because of chromosomal abnormalities. So while it is a sad event, it has prevented you from going through a pregnancy whose outcome would not be good.
So I want just to hold there. I remind our viewers that when the medical people are talking about abortion, it's not abortion that rings.
Let me call it miscarriage.
Yes, call it miscarriage.
Yes.
I've had a few concerns with, especially the discharge summary. Then it comes and then it's an abortion. Then you go home with that discharge. You will explain
what ulienda
kufanya nini.
I've seen that.
Let
me call it miscarriage.
Let's call it miscarriage.
So in this first trimester, you can get those miscarriages because of chromosomal abnormalities. But if we are going to have a baby with Down syndrome, I think it is important that the mother knows that I might have a child with Down syndrome. So there are those tests that are done in first trimester that will be beneficial. And then, now this is where your controversy comes in. If I do your screening for these chromosomal abnormalities, I will sit down with you and we will discuss what is going to happen to my pregnancy. Because if we have a child that is going to have hydrocephalus, for example, hydrocephalus are, the excessive CSF. If we are going to have a child that is going to have hydrocephalus, for example, for us in training and for my senior colleagues who are in MFM, you can talk to the mother and discuss whether she wants to continue with that pregnancy or not early enough. Because one of the other things that we have seen with patients is, why would we compel you to go through with the pregnancy that you know outcomes are not going to be very good. The baby is going to be born with a lot of issues. They go to a brain surgery immediately, and they're going to be entirely dependent on you throughout their lives. They're not going to live that quality of life that you would want. So there's now those questions that will come up, both ethically, but as doctors, we should give patients that information.
That information, whatever they do with the information, but they have it. They will say, I was told.
Yes.
Beautiful.
So that would be our first trimester.
And do we have those tests locally available?
They are available.
Oh,
at least at MTRH, we had. One of them is as basic as an ultrasound. But the others are still beta HCG. So that's what we... Yes.
They are available.
So the only one that maybe I might not know if it is available or not is something we call PAPPA. We usually just say PAPA. I'm not so sure if it's there, but in some of our teaching and referral hospitals, it is there.
Wow.
Yes. So you look for your gynecologist, look for your MFM specialist. They will guide you.
And they have this conversation.
If you are 35 years and above, and this is your first child as a female, then you are advised to seek some of these services. If you've had a previous child with Down syndrome, it was not a birth accident, you need to get your successive pregnancy screened for Down syndrome.
Actually, Doc, now that you've mentioned that, yes, we are already pregnant, and because we've talked about these genetic conditions, and remember, especially for us, the millennials, we were told, go to school, work hard, have your job, you know, husbands and boys will come later. Do we have a biological clock? Does it matter?
It does.
It does.
It does, because physiologically, the woman has a finite number of eggs that with every cycle they are producing. Which means as time continues, the number of eggs are reducing. But so is the quality. There's a saying that we have, it is anecdotal. I don't think we have proven it from studies. There's a statement that we have in reproductive health that the best eggs are around between 24, 26, 28 years old. They're the best quality. Okay? You can use it to talk to your teenagers about babies, but it is not a statement you can give to these 35 years old.
It's done.
You see? So the eggs are finite. They go reducing in number and probably also reducing in quality.
Okay.
But I have witnessed a 42-year-old first pregnancy, baby is okay. Yes. So again, every individual, every patient is different. Yes.
Okay. So second trimester is here.
Second trimester is now where we get the medical conditions in pregnancy. It is in second trimester where we will first diagnose preeclampsia, or what we call hypertensive diseases in pregnancy, around 20 weeks there.
Okay.
It is in second trimester where we will get our first diagnosis of diabetes in pregnancy, or gestational diabetes. Okay. It is in second trimester where the baby is growing bigger, and we might, if we have anatomical issues with the cervix, then you might also have another miscarriage for issues like cervical incompetence. So if the woman had issues with nutrition, it is in second trimester where it gets more pronounced, because the baby is getting bigger and they want to eat more. They are consuming more of your iron, more of everything. So if the woman was anemic, then in second trimester it will be very bad, because the baby now is taking a lot of iron from her. Okay. So this time we should have already known that you are pregnant. So for us to quantify the level of effect the baby has on you, we must know how many babies are you having. Because if you are having twins, then we expect the level of effect to be probably even twice what we would expect for a woman with one baby. So already we had started planning ourselves into this journey. If you come to me, if I did your first ultrasound and you had triplets and you told me, nimesumbua kupata watoto, wacha nikae na hawa. Nikakwambia triplets inaweza kuletea shida ya pressure nini. And then I meet you at 24 weeks and then your blood sugars are up, your pressure is up. I will tell you, ma'am, sasa hii inahitaji sasa tukue very close monitoring na
very close, yeah.
You see, because I had already seen huko mbele.
Yes.
Where and how your journey has started.
Yes.
Imagine if I met you at 32 weeks. Your blood pressure is very high, everything is very high. I don't know how many babies you have. Okay?
Yeah.
And then I do my ultrasound and it's there I'm finding you have triplets. And then now nasema, hey, what do we do with this lady?
It becomes everybody's emergency now.
Yes. The babies are small.
Yes.
You are very far from term. Your blood pressures are very high. We start scrambling about, and the consequence sometimes is that you might lose all of those babies, especially if the woman insists that I want to continue with the pregnancy. Yes.
Yeah.
So in second trimester, majorly is just to make sure, are we having these chronic conditions in pregnancy, medical conditions in pregnancy? If the answer is yes, are we starting treatment? And that's majorly what we are doing there. If it's cervical incompetence, we can fix a max stitch. Okay. We can still fix a max stitch up to 20. I think we can still do it up to 28 weeks. But that one is called a salvage.
Oh.
If the cervix is not very open, the amniotic sac is not bulging out, we can try position you in a certain way and put a max stitch and push you until 30.
I'm here trying to hold like
37.
This, not that we are salvaging.
It's called a salvage stitch.
Wow.
Because the one that we do in between 14, 16 weeks,
yes,
that is the right time to put it.
That is the ideal time.
Yes. But that one is if you have known before.
Yeah.
But you see, the problem with cervical incompetence is that if you want to make a diagnosis, a historical diagnosis of cervical incompetence, it means you should have taken this woman through a number of losses.
Yes.
But then you are not allowed to take her through losses. So that's what I'm saying. The ultrasound, again, that we do will measure the length of the cervix.
Yeah.
Below a certain threshold, we can make that diagnosis that this woman could be having cervical incompetence, and we can take you to theater and do a McDonald's stitch. So that is why when the doctor tells you we'll do an ultrasound in first trimester, second trimester, and third trimester, we are not trying to milk your insurance or money from you. We are just trying to prepare ourselves for a possibility.
A possibility. Hey, that one should be said in bold because...
Oh yes, I tell my patient that in the clinic.
Yeah.
I will require you to do 3 ultrasounds. At least. Not at the 3, but at least 3.
At least 3.
From the first time I'm meeting you to when we are delivering.
Yes. The rest will come when need be.
Yes.
However, we have at least
3.
3.
Yes.
I will not talk about so much about ultrasound because that's another topic for another day. Because also there are specific places that we've seen our doctors in general preference. Like I'll trust this ultrasound more than this ultrasound done by a particular person or particular machine or facility. But that's for another day.
Sure.
We have learned quite a lot. But take home message is what I'd want you to insist on about the preconception first and second trimester to our viewers. And this will also be a reminder to me when I'm doing the childbirth classes that these are the things that we should all emphasize on. Please take the mic, Dr.
Thank you. So for me, I think the journey of trying to get pregnant, getting pregnant is very unique. We don't have a one-fits-all for pregnancy. That is why we encourage each and every person who wants to get pregnant first to identify the specialist for herself or for themselves. For the journey of pregnancy, again, identify your gynecologist. And every trimester is unique with its unique problems. So it is very important that through every trimester you get professional help. By professional help, I mean we need to make sure that the baby is okay on one hand, the mother is okay also on the other hand, and all this is done through the physical examinations and the various laboratory or radiological tests that we do. Preconception counseling is very important for everyone, not only for those with conditions, but especially for those with conditions, because we must optimize the mother's physiology for them to better accommodate the pregnancy. Whenever the female's physiology is not optimized, then the complications tend to be more drastic and more severe than usual. Yes.
That is amazing. And you were supposed to conclude, and your conclusion has touched on something that will now be the conclusion of all. Mental preparedness.
Yes. Oh, yes.
I think what you have given as a summary,
Yeah.
it starts from here.
So, yes. It starts from yeah.
Would you now want to talk about it also in brief, because whatever you have said, we can't do all this when our mental status is in panic mode, anxiety, fear, all that, then also you will not do so much.
Yeah. Now, so mental health really is it's actually the pillar on which even your physiology stands on.
The pillar.
Yes. When your mental health is weak, by weak I don't mean that the individual is weak, but if your mental health is not properly, is not robust, is not properly taken care of, then even physiologically you will suffer, because you will feel this headache, you will feel this nausea, you will just feel that this is not, I don't want this, I don't want to live, I am not worthy. So our mental health for our women is for me is something that is very paramount, and it begins from taking care of yourself, knowing your limits, knowing what you can do, what you cannot do, what you can allow and what you cannot allow. It comes to social support, and by social support I mean the environment. Women finding themselves in an environment that is harmful to their mental state is something that I do not encourage. Not that I would become a marriage counselor.
Yeah.
But it goes without saying that absence of a proper mental state, can also lead to infertility. It can lead to loss of pregnancies. Okay. So while you're preparing yourself to get pregnant, then your mental state should be top notch. Your social support, your environment should allow for you to carry this pregnancy. Okay. That would mean that I would really encourage a lot of us to, you choose your spouses.
Yeah.
You choose the father of your children.
Yeah.
Parenthood, for me as a gynecologist, our interaction might end after you have delivered, but your interaction with your child and your spouse continues throughout life.
Yes.
And sometimes not having that proper environment will catch up with your child also. And I think it will be very unfair for you to struggle through the process of getting pregnant and pregnancy and bring forth another human being and add them to your to this environment that is not also conducive for you.
Yeah.
So let us choose environments, and I say this with a straight face. I am sure I will not be contradicted if I say let us women choose environments where our mental state is well taken care of. If that environment is not assured, do not try to bring a child into that environment.
Need I say more?
Yeah.
Thank you, Daktari.
Thank you.
I am very honored, and having you as a chair for the second time.
Thank you.
I think I have all the blessings now to host all doctors.
Now you can call them. And anyone who refuses, just tell me. I'll give them a call.
To my viewers, thank you so much for subscribing. Thank you for your shares, your concerns, and your stories. We keep on answering them because we believe everybody has an untold story. Your story is yours and it's authentic. Please keep on subscribing and sharing. We are at the Little Cave. Come and pay them a visit. They have accommodation and a restaurant. These episodes are brought on your table by Chanuka Studios. Their offices are in Kondele. Engage them if you have an event, photography, or video. I remain your host, Shikari Rosemary, your doula, childbirth educator, and lactation specialist. Till next time, bye.